So welcome to the two-part webinar series tonight, Implants 101, a technician's approach for success. It is being presented by our very own Jeff Carlson, CDT. Today is part one, pre-surgical treatment planning and considerations. And now it is my pleasure to introduce Jeff Carlson, CDT, Senior Implant Specialist. He has extensive experience in both the dental laboratory setting, as well as working with the dental implant manufacturers in the areas of education and technical and sales support. He has lectured both nationally and internationally on dental implants. Jeff is the primary author of a 300-page fully illustrated cookbook for restorative doctors and is a co-author of a corresponding restorative manual for auxiliaries that has been distributed in 8 countries. Jeff has also developed a 2-day training program helping clinicians improve their presentation skills, which has been attended by more than 200 dentists from 16 countries. And tonight, it is our honor to showcase him for your live viewing pleasure. Take it away, Jeff.
Thanks, Jessica. You're always so awesome with the introductions. And welcome, everyone. I am so excited for tonight. I'm finally not talking about full arch and all on X and things like that. We'll be learning things that help support those type of treatment modalities. But really, this is something that is very dear to my heart. I've been very fortunate and blessed to have many clinicians and different people over the years that taught me so many things. And today we keep seeing so much technology advancing and people getting involved. It's more like you just need to know how to click a mouse. And if you're good on a computer game, you're into the dental laboratory phase of things for as far as my technician friends that are joining us. And so I'm glad that we have a combination. It was intended for that. We have dental technicians on this. We have some surgeons on the call as well as restorative doctors. And I see we even have some restorative team members as well, some auxiliaries. So this is really meant for everyone that's being involved with implants. And the title is exactly that. It's Implants 101. Some of it's very fundamental, but no one's teaching this really anymore. They're all teaching such advanced things. And so for many of you that are maybe starting your dental career, it's hard to find this information. So I really do truly hope that you'll find this very helpful and look forward to taking any questions as we move on with the presentation. This is part one. Part two, you'll get at the end, there's a link for it at the end to sign up if you haven't already. It's December 7th. It's a Wednesday as well for 2 hours. That will actually be more focused on overdentures. And that will also segue into some of the all-on-X type of cases. But today, we're really focusing on implants, crown and bridge. So I need to give my quick disclosure. That I do have a financial interest. I am a full-time employee of NDX and Sequence, National Dentex, and that they are paying me my salary and using their computer. So the other thing is, as far as my commercial support, as I mentioned, I am a salaried employee. All right, so the information that I am sharing with you is something that like I said, I've learned over 30 years of being in implants. I think my first implant course was actually, oh my gosh, my first implant course was 1983. So it's been 40 years of actually learning a little bit about implants, but really involved for 30 years. This was me in my early stages of doing my book. And so let's get into it. One of the things that has been very beneficial has been able to take a lot of complex information and try to organize it in a very repeatable from a mental capacity as well as a diagnostic capacity, some very complex concepts with implant dentistry. And one of the things that I have learned over the years is that the way that we're able to really pre-surgical treatment planning is a key to success. And over the years, we've been able to kind of zero in and came up with 4 key concepts to pre-surgical treatment planning. This is all before an implant is actually placed. And so I'm going to expand on all of these topics in the next 2 hours. But it's basically, we broke it down to patient's expectations, restorative options, basic biomechanics, and the team concept. So let's talk about patient expectations. I define patient expectations as what do they, the patient, expect their restoration to feel like, function like, look like, and then of course cost. And if you, our clinician, our doctor friends, if you're talking with a patient or even team members, you're talking with a patient, if you could not, in their words, explain what is it that they are expecting the restoration to feel like, function like, look like, and cost, then we're missing some pieces to the puzzle here. Because once you get that, then that's going to help direct you to the second step, which is based on that patient's expectations. What type of restorative options, prosthesis, are you going to fabricate for the patient? Because if you don't know what they expect, how do you know what you're going to make them? You may have in your mind what you would do for that patient, but is it really what they're looking for? And believe it or not, some of the biggest failures we have in implant dentistry, it's not that the implants failed, the prosthetics failed, is that the patient's expectations were not met. And we'll talk more about that as we move along. So the restorative options, now you start looking at, okay, we know what they want. What do we have in our bag of tricks, if you will, to fabricate? Then now that we know what we're going to construct for this patient, then we have to evaluate what are the basic biomechanical requirements for that type of prosthesis. And this is going to be extremely important because patients expect their restorations, their dental restorations, let's call it conventional dentistry, to last a lifetime. We probably all have heard that. But how long do they expect their implant restorations to last? And typically, we'll say a lifetime and 2 days. They have very high expectations. So it's very important that biomechanically we design these restorations to meet the expectation. And once we have that information, then the quarterback of this, which often is the restorative dentist, could be the implanting surgeon as well, one and the same. Or maybe you have a technician that's, really right there, your right-hand person to help support you with this. But it's a team concept. How do you share the patient's expectations, restorative options, and the biomechanics, share that with the entire team? So the surgeon knows from their perspective, what's the patient looking for? If they, even when they're coming in to say have a consult with the patient from the restorative practice, the referral practice, also for the laboratory to understand what the expectations are, and also, getting the patient involved is very important. So here's our topics that we're really going to go and dive in much deeper into this evening. We're going to get into about implant placement protocol and options, implant loading, the pros and cons of some of the different concepts, a little bit about prosthetic connections, impressions, options. And this is important for us, indications and contraindications. Many people know there's different ways to take an impression, but which one should you choose, and which ones could compromise maybe the outcome. So we're going to cover some of those tips and pearls for you this evening. Then we're going to get into the actual prosthetic options, some of the advantages and disadvantages. And I always like to do pros and cons, advantages, disadvantages, and then indications and contraindications. And then of course we're going to biomechanics and then the team concept. One of the things that I have relied upon for many, many years is a lot of information I've learned from Dr. Carl Misch and the faculty at the Misch Institute. Huge kudos to Dr. Misch for what he did all these years and through the Institute. He has several books, but this one, any of you that, I got to tell you, if you don't have this book, it's one of the older ones, but this has been my go-to book. And one of the things you're seeing here, this terminology, these acronyms, FP1, FP2, FP3, and there's FP4, there's FP5. This is terminology that clinicians that, based on where you had your training and maybe even some bit of your age, you're familiar with these terminologies, but sort of younger technicians and younger clinicians and maybe younger auxiliaries may not be aware of this. And you'll be talking with someone and they'll say, oh yeah, I'm going to do an FP2, or what would it take to do that as an FP1? And so I want to share that with you, but this book is a must-have book. I highly recommend that you search it out and get this book. It's a must-have book. So FP1, means that the prosthesis is fixed. We're talking about fixed prosthetics tonight. It's fixed and it replaces only the clinical crown. FP2 replaces the clinical crown and it replaces a portion of the root. And it also could replace portions of the pink based on the scenario. And FP3 means you're replacing the missing crowns of gingival and maybe even a portion of where the patient has lost bone. So that can be referred to sometimes as like the edentulous area. So let's go a little bit more deeper into the FP1. So here's what you're looking at for FP1. You're really only replacing the clinical crown in this scenario. That's FP1, okay? It's really simple concepts, but it's great. It's easy to understand and very quick to verbalize with other people. So that's FP1. FP2, now you're going to see that we're going to replace the crown and maybe some portion of the root. And so here, where we've had more bone loss, so the technicians will, maybe start faking in sometimes a neck of a tooth. Maybe it's an embrasure that's added a little bit more to that. But it's really talking about, that aesthetic zone from when they smile, what you're seeing. And then an FP3 is going to be beyond the clinical crown and the root and into other structures, specifically the alveolar ridge, reconstructing that. So when a patient smiles, the visible matrix all looks natural. So FP3 is going to be more so, that's for severely resorbed ridges. And we see a lot of the all-on-X cases, the immediate load type of full arch reconstruction cases are considered an FP3. A lot of them today, we're seeing a kind of I don't want to say a twist, but an interest in going to FP1. So it's a full arch where we don't need to replace bone or don't need to reduce the bone to create room for the prosthesis inner arch space. And we're able to do more with crown and bridge and make it what we refer to as an FP1 prosthesis. So I just wanted to quickly kind of talk about these three terminologies just to make you a bit aware of that. Because a lot of times when you are reading literature, you're hearing other clinicians speaking, that you're hearing them use those terms. So now you might have a little better affinity for what they're actually talking about. So here's just kind of a snapshot of all three kind of put together so you can see how the bone has resorbed here. And that's usually what's going to have you change from FP1, 2, and 3 is based on alveolar ridge, available alveolar ridge. So we're going to get into now about placement protocol. And this is something that I think there's parts of what I'm going to share with you that some people may not realize. So hopefully you get some good tips and pearls from this. So really what we're looking for is there's a traditional two-stage, what we call unloaded healing, where, it's a two-stage surgical procedure. One to place the implant, second surgical procedure is to uncover the implant. Then there's single stage, also referred to as early loading. That's where the implant's placed, and also a healing abutment or a tissue-forming abutment is placed to help contour the emergence profile, which is all very advantageous when we're doing anterior restorations to develop that soft tissue. But there will be an exposed component from from the first surgery. So it's only one surgery. There's not an uncovery with that. And then there's the immediate provisionalization, referred to as immediate loading. And we're going to go a little bit in depth on each of these topics. So we're first going to talk about, this is going to be the unloaded or two-stage protocol. And so we'll talk also about the pros and cons of when you're doing these different protocols, how to make some good informed decisions for that. So in a nutshell, those of you probably this, again, Implants 101. So first stage surgery, they're going to create the osteotomy, seat the implant, place a cover screw, as you see here, onto the implant like a lid on a jar. And then they're going to suture the tissues over that. And so the patient leaves and all they really see are a few sutures at the time. So that is a two-stage. That's the first stage surgery of the two-stage. Then after the implant is integrated, whatever time that's deemed necessary for the particular patient, then it's the uncovery, what's referred to as second stage surgery, or uncovery is another common terminology people use. And that's going to be a smaller incision that's going to be made. And then the cover screw will be removed. And then possibly a healing abutment, a contoured healing abutment, which are really nice to utilize the different diameters and different heights of these healing abutments or contoured abutments to really help form that nice emergence profile. You're going to find these contoured, oversized, if you will, healing abutments are really advantageous in your molars and even your premolars, but molars especially, because we don't want to have our crown end up being like a tomato on a stick, so to speak. Where we want to have a nice emergence coming out. One, for aesthetics. Secondly, we want it for function as far as hygienics as well. We don't want to create food traps in these cases. So the patient then would leave with an abutment placed. It's also advantageous for anterior restorations, but I'm going to show you how we're going to do that. Anterior restorations are probably best served by doing a actual provisional crown, and we'll talk about that as we get to that topic. So that was the unloaded. That's how we did everything. That's how we did everything 40 years ago, 30 years ago or so. So early loading, then this is where we're going to have called the single stage surgery, and it's called early loading because the componentry is actually exposed to the oral environment. So there's a higher propensity for the implant to bone to implant interface to be affected by patients' functioning. This is where you want to watch out for more softer foods because even though it's out of occlusion, biting on a raw carrot could still, put a lot of undesirable loads onto an implant that's maybe only been placed for a few weeks. So the concept here is the same: create the osteotomy, place the implant, but instead of the cover screw, we're going to put on one of these contoured healing abutments and suture around that. So that's the early loading. And then the immediate provisionalization or immediate loading is what we kind of just saw, but the difference here is we're going to, instead of put on a healing abutment, we'll actually utilize a temporary abutment. There's different varieties that these abutments can be made from. And now with what we have with CAD/CAM, it's so easy to produce different types of abutments. But here we are, we're going to place the abutment. And then and sometimes people use the final abutment. The challenge with using a final abutment instead of a temporary abutment is that you can't always predict what is going to happen with the CEJ line, with the gingival tissue, with the biological width from the healing process, especially if there was any bone grafting done, any soft tissue grafting. You have dimensional changes in the visible anatomy that can affect the aesthetics of a case. So if you had a final abutment and the patient had some bone recession, and tissue follows bone, we all know that, and now we have some bone loss, tissue loss, and now we're starting to see the abutment itself, the collar of the abutment, if it's not a zirconia abutment, it could be visually unacceptable to a patient. And now you have the expense of a final abutment because you're going to have to go back and redo that abutment. So typically people would use a provisional abutment in this scenario for immediate loading, and then a temporary crown contoured to the ideal contours. That way, when the clinician is suturing around that, so I place the implant and then they suture around that, they're not just developing a circumferential emergence profile, it's actually getting buccolingual, buccopalatal profiles as well as mesial and distal to help shape the interdental papilla. So it gives you much more control when you have a temporary crown utilized in this scenario to develop and manage that soft tissue, the visible matrix. So we're going to talk a little bit about some of our pros and cons now, because this is where people can get a little bit into trouble. So, oops, sorry about that. So there's 4 common loading protocols. And so we just covered the 2-stage, the early loading, and then more or less the kind of immediate loading. But one thing about immediate loading is that typically you're going to want to keep that crown out of occlusion. You do not want, as you see in the far right, an immediate occlusal loading. That's not desirable. The patients, you want to do progressive bone loading, sometimes in that softer bone, especially in the maxillary, even sometimes in the premaxilla. Progressive bone loading means that the crown itself, which would put the crown, the abutment, and the implant, because it's all connected, into function, a direct, immediate function from loading. Whereas as you see here with non-occlusal loading, there's a little bit of you keep it out of occlusion with the theory, then it's not going to have that much occlusal loading for either direct loading, axial loaded, or off-axis loading. But then again, diet is going to be very important. Patient bites on something hard, that gap is taken up by a hard bolus of food of some sort, and now it's immediate loaded. So you want to be careful that when you use a immediate load protocol with a provisional crown where you're close to being in function, that you want to have good stability. You want to have pretty good bone quality. And when I say stability, I'm talking about initial stability in time of implant placement. Usually you're looking for, on a single implant, a lot of the people, the clinicians I really respect a lot and have learned a lot over the years from, on a single implant, we're looking at ideally around 40 newtons of insertion torque immediately, maybe is not much less than maybe 30 newtons of insertion torque. Keeping in mind that when you place an implant at the time of placement, it has pretty good torque. But what starts happening within 7 to 10 days, what happens almost immediately, within minutes, the modular elasticity of the bone, say type 4 bone, and you get 45 newtons of insertion torque, you come back 10, 15 minutes later, and you put another torque device on it and check that, or maybe you're using your resonant sounding and sensing that to see what kind of torque value, reading that you're getting on that. It's going to be less. Typically, it'll be less right away, just because the bone, the modular elasticity of that bone, it kind of gives a little bit. But at 7 to 10 days, that bone that was in contact with the implant is actually dying back, and the osteoclasts are starting to develop now. And that's the weakest part of the bone to implant interface, is after that 7 to 10 day period, upwards to maybe somewhere closer to 6 weeks, maybe as much as 8 weeks, based on a lot of conditions, patient's health, smoker, non-smokers, uncontrolled diabetes, things like that. They're way over my head. I'm just a technician, so a lot of these things, I'm just restating what I've heard and from, again, my clinician friends. So let's take a look at some of these protocols here. So pros and cons. So doing it unloaded, a 2-stage protocol, obviously it prevents loading the implant. It's more predictable and poorer quality of bone. It can be more predictable. Also, it's used for adjunctive procedures, meaning bone grafting. If you think about when you bone graft, that the idea is that you want to have primary closure over that graft site so that you don't have food, bacteria infiltrating your graft and causing it to not be the most ideal regenerative process that the bone graft you're hoping to achieve with it. Also, sometimes for smokers, maybe it's best to cover that. Now, if it's a full arch, you're talking about a patient wearing a denture for a while, maybe a soft liner. It's a good idea. And then the cons to that is it does require 2 procedures. The provisional, based on a single unit, maybe how do you keep that from even a flipper, if you will, making contact onto that ridge. It can be difficult based on inner space. Can you create a gap? And then the flipper's weak, or our different little temporary bridges that we can make. And then it just takes more time to get to a final. So early loading, similar here, we've got, good news is it's one surgery. The gingival tissues, you have a more ability to, the tissues to mature, if you will. During the integration period, the tissues are maturing, become more stable. So when you are in the aesthetic zone and you're getting ready to do a final impression, be it analog impression or an IOS, say you're scanning it, the tissues are, if I may use the phrase, mature. They're healed. They're going to be stable. You shouldn't be seeing changes in the interdental papilla height, contours, CEJ line, etc. So that's advantageous. And then it does allow for that progressive bone loading, which is very advantageous in some situations, especially if you've done a sinus lift and you placed an implant you have enough host bone to put the implant through the host bone and then into the sinus that's been grafted. And what I've heard, and I believe the numbers are still pretty similar, that if you're going to do that, you want to have at least 5 millimeters of a patient's host bone, so that implant has at least 5 millimeters of host bone before it gets into the sinus, the sinus graft. That's to give stability, because if you have less than that, then you're going at risk of having movement of that implant, and that movement of an implant is not good, especially for this integration process. So, but progressively bone loading can be very advantageous for that softer bone to help give a little bit of stimulation, so that bone develops into some good quality bone. The cons, again, a little bit about now you have this metal sticking up, and it has to be at least a millimeter. These abutments, these healing abutments, really need to be at least 1 millimeter to 1.5 millimeters taller than the height of the gingival tissue. Now, if not, what happens, the tissue has a tendency to invaginate up over that and grow over sometimes that healing abutment. Now, that I've had clinicians tell me that's a good thing, because then they can come with their laser and recontour that and remove some of the tissue. So it's based on your school of thought, how you what you want to do. So I just want to share that with you, that if you love the tissue, you think the tissue height's right where it's at, if you go if that level, the top of that abutment's level with the tissue, you're very likely might see some overgrowth of the tissues there. And then again here, if there was bone grafting needed, then you don't have primary closure. It doesn't mean it's not going to, the graft is going to fail by any means. It's done a lot. It's just, you need to be aware that there's a channel, if you will. There is an opening, might be a macro gap, that where bacteria can get in, because it's sutured. The tissues do not have an apposition yet to that healing abutment to kind of help prevent some of the unwanted debris, for lack of a better term, into your graft sites. And it can, if you didn't get good stability, it could increase the loads transmitted, as you see here in the bottom right. So just some points to keep in mind about this for early loading. I think we're seeing this done the majority of the time, if not the immediate load as we're coming into next. But just these are some factors to take into consideration so you don't get blindsided. Now, the immediate non-occlusal loading, where we're actually going to have a provisional crown, again, the pros, I think the pros do outweigh the cons, for all the things that we kind of already talked about. Patients, they're also more patient with you when they have a nice smile. Even though the tooth is not in full function, it's in a full function smile for the patient. So they're not looking at trying to, embarrassed about, a flipper, or they're embarrassed about a splint, etc. The cons, you got to have a good stability, good initial stability with that. Patient really needs to be compliant as well about the soft food. And again, you can really be distributing or transferring loads, significant loads, to that implant to bone interface through the restoration, abutment, and implant connection. Full loading, boy, this is you just really don't want to do that. There's really not too many situations where you want to have it into occlusion. I mean, the cons outweigh the pros on doing this. It's just a greater risk for failure. And, you really should evaluate, why are you doing that? And a lot of these patients too, based on the number of units, it may be advantageous to have them in a night guard. One thing that I learned, a little trick that we did in the laboratory for our crown and bridge multiple units, where we had them in a provisional, is in the night guard, relieve inside the night guard around that crown. That way, if the patient still does some clenching in the periodontal ligaments of the adjacent dentition, allows movement, the crown itself, the implant crown, is not getting pushed by that splint at all. So it just takes a little relief inside, and we seem to have had pretty good success with that as well. So implant options. You're saying, what do you mean implant options? Well, there's what we call the tissue level implants, where the prosthetic table or the prosthetic platform, the prosthetic connection is actually going to be above the tissue or at tissue level. So here you see the bone, and then you have the smooth, usually machine collars are very common. And many implant companies, these are great implants still to in the right situation to use these implants. What most people are using, and most of you are probably familiar with, are the bone level implants, where the platform of the implant is at or slightly below the crest of the ridge. Now, I want to share a tip with you here that hopefully you'll find helpful. When you are dealing in the aesthetic zone and you're looking at implant placement, a lot of my training I kept hearing early on is about, the platform of the implant flush to the bone. Well, we all know that when you create an osteotomy, you're going to have there's usually going to be a sharp angle somewhere. The edge, the ledge right here, okay? And your body does not allow for any sharp edges, so the bone will automatically remodel. Some people would call that saucerization, was a name for it. It still is a name for it. And it doesn't necessarily mean that there's any failure, but the bone remodels, and as it rounds off, it creates a little cupping or a little saucerization. So in the aesthetic zone, this could be a little bit of a problem. So just a tip would be to consider placing your implant subcrestal 1 to 1.5 millimeters, so that when you do have some of that bone remodeling, that you still have the platform of the implant, the top of that implant is at, ideally, hopefully it's at bone level, and you'll have plenty of tissue to provide an aesthetic situation for you. So that's a little tip that we found to be quite helpful in the aesthetic zone. So let's talk about, implants. So we have single stage type of implants, the tissue level, I should say, which is a single stage implant. Bone level implants can be a 2-stage or a single stage, and I'll show that coming up here. So commonly implant lengths, what we're seeing today, many manufacturers will have implants somewhere around 6-7 millimeters, going up to like 15 to 16 millimeters in length. The most common diameter implant really is around 12 millimeters. And that's kind of a feel good as well, 11 to 12 millimeters. Most people feel like if you can get an implant for a single tooth replacement, you get 11 to 12 millimeter implant. And let's talk about diameters here as well. And you get say about a 4 millimeter diameter implant, 3.8, 3.75, different sizes the manufacturers have. But a 12 by 4, let's say, diameter, 11 by 4 diameter length implant, they feel pretty good about you're going to get good success with that implant. You're not overloading potentially that implant. It's not like you're putting a 3 millimeter diameter implant that's 6 millimeters long, replacing the first molar, in other words. So let's talk about implant diameters, because now we're always talking about platforms of implants. And I'm sure most of you are familiar with the platform switching. And platform switching is going to means that where the connection of the abutment to the implant is not to the outside necessarily where the bone's going to be here. This is bone level right here, or bone level could be up here, but the platform or the connection is away from where the bone would make contact to the implant. So the platform is switched. And so the prosthetic connection's inside. This is pretty commonly done in a lot of systems now. It's nothing you can do about it as a clinician. It's either there or it's not there. Another thing to keep in mind too is because we're doing so much with immediate loading, be it the full arch type of cases or even the single cases, that based on implant manufacturers, they had different thread designs. Some have very aggressive threads, and some implant companies, they have they have a lot of different styles of implants. But some people don't realize that there's something called the major diameter of the implant, which is if you took the threads off the implant, just strip the threads off, that cylinder that you have there is the major diameter. I'm sorry, I just said that backwards. The major diameter is the outside of the threads. My apologies. The blue line here, that is your major diameter. The minor diameter is the actual body. So it's the minor diameter, that's the body. Why is that important? When you're drilling and you want to get good initial insertion torque, you need to be aware of what's your bone densities, D1, D2. We're going to talk about that coming up as well. That when you get into that denser D1, D2 bone, that you're going to need to at least create an osteotomy that will match the minor diameter of the implant, or you'll very likely just strip out the bone or even strip the internal aspect of the implant with the driver, because you're trying to force something. I don't want to say a square peg in a round hole, but you're trying to force something too large into a small, tight hole. Tight meaning dense bone, because we're talking about D1, D2 bone, different than D3, D4 bone. So the things to keep in mind too, and this is great for a lot of you that are doing this, the 3D imaging, and you're designing cases, and whether you're doing it for your clinicians or you're doing it yourself, doctors, that you're looking at, sometimes we're splitting hairs to get an implant in. We got to keep in mind about bone density and about the actual thread design or implant design. So let's take a look now at the the two-stage implant system, if you will. And so what we're looking at here, when you talk about a two-stage implant, that means that the two-piece implant, or the implant's always one piece. The abutment connected to it. The key here is that with a two-stage implant system, the implant is typically bone level. The abutment is added. The margin of the crown is located on the abutment. So this is key compared to what we'll talk about the single-stage implant coming up in the next image here. But the two-stage implant, the margin will be on the abutment. That gives the laboratory some versatility. So you can do a two-stage implant system in a one-stage protocol. Place the implant, place this abutment, as we talked about the immediate loading. Whereas a dedicated, sorry, I didn't get my words off of there. I apologize. A dedicated single-stage implant, the margin is on the implant, and you cannot modify that. So implant placement of a single-stage implant, especially if you're going to do it in the aesthetic zone, is really critical, because that's where your margin, your crown, is going to be dictated by the implant position, because the margin is actually on the implant. I hope you can see that okay. And I apologize, I didn't get the writing off of there. So let's look about connections here. Prosthetic connections we're referring to. So there's a few of them. The common ones, we started off with external hex. That's all we had, 50 plus years ago. The most common that we're using now is the internal hex. And there's a lot of different configurations of that. But basically, the implant's got the female hex, and the abutment has the male hex. Then we have what we refer to as an internal Morse taper, where it's basically the opposing tapers that are locking the components in. And then also there's companies that have these lobe, if you will, internal lobe implants. So it's an internal connection as well. So that's just a little bit about the connection portion of it. Now, it can get into abutment options. It's a lot. This is why you want to work with a laboratory that really can understand, about this. I think the good news is with technology today, with our CAD CAM abilities, that between a design and machining, this list kind of gets trimmed down a bit, but I think it's still good information to kind of be aware of. We're not going to dwell a lot into that. That's what your technicians are there to help you with. But I want to talk about impressions. So this is a very important part that we're going to talk about both analog and digital impressions. So with analog impressions, there's really two types of impressions that you can be taking: an implant level impression or an abutment level impression. And we'll go into that in a little more depth here. So there's three common impression techniques. Again, we're talking about analog here, and that's going to be referred to as an open tray or direct, closed tray or indirect, and then conventional, which is basically it happens to be an abutment, a prepped abutment, but it's like could be just a conventional crown prep, let's say. That's why it's the phrase conventional. These are not my terms. These are words that it's all in the journals and what have you, the manuals, and we've been using this terminology for many, many years. So we're going to get into those a little bit more on pros and cons and how do you choose which one to go for. So let's take a look at a snapshot, the indications and contraindications. An open tray, when you have an implant that is placed more than 15 degrees, and these are just some average numbers, you have to pick a number somewhere. So we're just picking, it's not like, well, if it's 16 or if it's 14, I can go ahead with it. It just gives you a ballpark, something to think about. So if it's an open tray, you really should use an open tray when there is greater than a 15-degree divergence. What we mean by that is that the path of this impression coping coming out with the impression, that it's going to come, if it's more than 15 degrees, that it's going to be pulling in that on a closed tray here. I'm sorry, I'm trying to explain this. I was pointing to the wrong image. If this was more than, for a closed tray, where you're going to draw the impression after it sets up with, maybe medium or even heavy body impression material, when you pull that impression tray up, that if it's more than 15 degrees divergent, if it's divergent, then when you come up, it's going to want to have a tendency to distort that impression. So an open tray, because it releases right at the implant level, and you'll see that coming up here, that's going to allow for more divergent implants. You're going to want to use an open tray. When in doubt, use an open tray. If you're just getting started with implants, you want to have an inventory of both open tray impression components and closed tray impression components. Open tray impression components also require a little more inner arch, the patient's ability to open a little bit wider. Closed tray is fine when you're less than 15 degrees. And then conventional, it can be done either with your analog or your digital. So let's dive a little bit deeper into that. So we're looking at the open tray or the direct right now. And so it can be used for single unit, multiple units, whether you're using cement retained restorations for your final or screw retained, it's fine. Straight or angled implants. Even with an open tray, about the max angulation that you can get an impression with our analog protocol is about 35 degrees, maybe 40. Implants, there's some limitations here. You can't just put implants anywhere and be able to impression them. So there need to be, the target should be to have implants, especially in crown and bridge, freestanding implants or unilateral bridge type of implants, where you're not connecting a full arch, where with a full arch, biomechanically, you get cross arch stabilization, which is can withstand much better off-axis loading, horizontal cantilevers, as well as mesial, distal, or buccal anterior, posterior cantilevers as well. Contraindications: patients with limited inner arch. Well, why is that? Well, you see the screw here. If this was a closed tray, the impression coping stops right about here, pretty often right at the height of the adjacent teeth. An open tray, it's going to have a long, tall screw because that's going to protrude through the impression tray, so you can unscrew that. And so that means that you may have to either get your fingers in there to loosen that coping or seat that coping, tighten it or loosen it, or you may have to get a hex tool in there to do it, and that could require some significant opening. I've always said to people, quite a great way to determine if a patient's a good candidate for implant dentistry: grab your hex tool and tell them open wide. and take the hex driver and go back to the second molar. And if you can't get it on the occlusal of that second molar, they can't open wide enough. What are you going to do when you're trying to seat a crown there or trying to work surgically in there, place an implant? Not saying the patient's not a candidate, just trying to give you a quick little tip. Another quick little tip I'll share with you. Take 3 fingers, and if your patient can open wide enough and get 3 fingers. Now, if you got little tiny fingers, maybe throw 4. You got big old fingers, maybe 2.5 fingers. But just quick guides that just helps keep you from being surprised when you tell a patient open wide and they go, and you say real wide, and that's it. And so things to think about. All right. So let's look now direct. Oh, so the reason they call this the open tray, the direct technique, is when you take the impression, here you'll see it. So the impression coping, here's a tall screw sticking up, right? Now you put the impression material, syringe around the coping itself, fill up the tray. You have a hole cut out in the tray, hence open tray. And then before the material sets up, you have to expose that. The material sets up, you unscrew that screw, which is actually engaging the internal threads of the implant. Now it's disengaged. Now when you pull that impression out, the body of this impression post, see all these undercuts here? That is locked into the impression, hence the word direct. The impression coping is directly into the impression. And here's just a full arch edentulous arch with 5 implants. Same thing. You see the top of the impression copings here. Impression sets up, unscrew, and remove that. So that's the open tray. It's considered to be the most accurate way of doing things, as far as on the analog perspective. And I'm even going to say in some situations for digital. We'll talk a little bit about that coming up here shortly. So closed tray. Indications, again, single tooth, multiple unit, cement retain, screw retain, need to be pretty straight up with these. Greater than at 15 degrees, could be some tearing of your impression, distorting of your impression. That could be a bit of a problem. So the closed tray, the impression, it's closed tray so that there's no opening in the tray other than for retention. Like, whoa, I'm sorry there. What just happened? Let's try this again. Jessica, can you confirm that I am doing okay here? Am I back?
You're back.
All right, I'm sorry. I don't know what happened. It just disappeared. I wasn't even touching my mousey. Okay, so back to the closed tray. Other than the, little openings for retention of the impression material, but it's indirect. So it's a closed tray, also referred to as an indirect impression, because when you remove that impression tray, the impression coping is still in the mouth. It's still screwed onto the implant. You have to remove the impression coping, attach what you see here on the right, the silver portion is an analog screwed onto the impression coping, and then reinsert into the impression. So hence the name indirect, okay? They're still quite accurate. It's just there's a propensity for error because someone may not line it up and push it in too hard, or if you're using a light body impression material, it may not give enough resistance and you might push it in the wrong position. Conventional indications, these are really only for your cement retained restorations. It's a crown prep. Keep in mind, it's a crown prep. It just happens to be metal instead of dentition. Yeah, I mean, packing port is usually not going to be much of a value because it's going to go under, there's no attached gingival, it's just going to disappear anyways. So impression options, what refers to as far as for digital, then what you're going to see here is our scan body in place. And, based on what system you're working with, you're going to get all this information, what you need to send to the laboratory. So I'm not going to really dwell too much on that tonight. Those of you that are scanning, this is really fundamental. I'm just bringing up the point that, the digital aspect of this. So the labs, you're going to pre-order the scan bodies, full arch scanning, just, single unit. Look, it's all about occlusion really when you get into implants and stress distribution, of course, aesthetics and other things. But if a laboratory, when we get quadrant models in a laboratory, all we can really do is we can get centric occlusion for you, and we can get working. We have no idea on a balancing movement on a quadrant impression what is happening on balancing to clear any balancing interferences. And balancing interferences, as I think any of you know in Occlusion 101, are some of the most detrimental interferences to have in implant dentistry, because you have an ankylosed tooth, for lack of a better explanation, ankylosed tooth, implant fixated in bone, and now you're going off on a cross arch, now you're getting a balancing interference, and that can be magnified and be a real problem. So I really think that your patients deserve, in my own opinion, patients deserve to have the best that we can provide them, and your technicians need information. I know a good friend of mine, Dr. Rick Ferguson, posted up at the ISOI recently saying a quote that I have said for many years is, there's never been a technician that's asked for less information. So we may be greedy at times, but we're doing it for the best interests of the patient and for you as well. So if you're not familiar with the iOS scanning, basically, you're going to be scanning the tissue. You'll be scanning the scan body to get the implant position, scan the opposing arch, scan a bite. So this is kind of what your scans are looking like. And then you've got, scanning the gingival tissues, the scan bodies, and then that gives the information for the laboratory to print these models. A lot of single crowns are being done modelless, not even using a model. So, we're not going to dive too much into that tonight. This is Implants 101. So, anyways, I hope you guys are doing okay so far. A lot of information, like as Jessica said, this is actually a full day course. Of course, I took out a lot of slides, but I really wanted to hit some real high level points. So I hope everything's going okay for y'all digesting this, and you're sticking with me so far. So let's go back to our concept of the 4-step process of pre-surgical treatment planning. Patient's expectations. Let's zero back on that. So it's perspectives. It's about perspectives, the patient's perspective. And perspectives, it's not what you look at, it's really what you see. In other words, if you look at this real quickly, are you looking at a patient frontal facing you by the front or facing a profile? Which are you seeing? Of course, you can't answer me, but you're answering yourself. So those of you that are looking at that, if you're seeing a profile, yeah, here's the nose, there's the profile of the patient. It's a profile. If you're seeing it straight on, it's just like the face was cut right in half. So it kind of just depends on, what you're seeing. So perspectives, it's very important to get an understanding what the patient's perspective is on that. Patients' expectations also are involved about the motivation. We as humans, we buy things typically that we want, not necessarily what we need. Wants are often a quality of life issue. I want to be able to eat anything. I want to be able to smile and not have to cover up my smile. Needs, I need a new crown. I need bone grafting. I need an all-on X. I need something. Needs justify the wants. So be sure that you're talking with your patient about wants and needs. Wants are what you're trying to uncover. That's the emotional part of all this. And trust me, my friends, if you're just getting started in implant dentistry and are just getting started in some of these bigger cases, these $15,000, $25,000, $30,000, $60,000, $70,000 cases, if you don't think a patient's expectations are high, then you're going to have some real surprises coming your way. So again, keep in mind it's what it's going to look like, feel like, function like, and cost. One of the things that we've learned over the years that patients don't really understand the consequences of bone loss. This is a great photo. This is an old photo, but this is truly what happens when you lose teeth, you lose bone, and when that happens, some people will say, as my wife does a lot of lecturing, Kathy Carlson, I'll throw that out to her. I've learned a lot from her over the years because she's right there communicating with the patients, is about how do you explain bone loss to a patient. Here you see clinically we can explain it, but this is what it means to a patient. This is really what patients will understand what bone loss is. The challenge is, how do you communicate that to a patient if you don't have, photos or models or some things like that? So just know that patient to understand the consequences of bone loss is really important. It's more important than many people think. That's because bone loss, when you lose bone, you lose tissue. When you lose tissue, you start, your anterior aesthetics can be affected by that. You get the black triangle disease. If you're talking about a denture case, now you start seeing what you're seeing here with the whole facial profile, the corners of the mouth, the crow's, even, the eyes, the crow's lines. It's a lot. So bone loss is very important, and a patient needs to understand. Maybe you all don't ever. Maybe some of you never heard this phrase. Dental implants have a nickname. They're called bone maintainers. If you had an extraction socket and you put an implant in and didn't do anything else, typically the body doesn't recognize the implant as a foreign object, and it's going to grow around that. So even if you never loaded it, it helped to maintain that bone, as opposed to having a deficiency, as you see with Pontics and Crown and Bridge Pontics that we've done for many years. So again, patient expectations, it's about quality of life issues. These are conversations that you need to have. That's a whole lecture that, on this alone, that could go on for more than a couple hours. But aesthetics, again, what's natural to them? What are they looking for? And then also, what understanding the treatment, the process, things like that. Just really, what do they expect the whole process to entail, and what is the result of it? How are you going to be measured? So now that we know the expectations, then what we're going to need to think about is, we need to start thinking about what are you going to make? So our restorative options. So let's tap into this a bit here. So how do you choose what type of prosthesis are you going to make for a patient? If you're doing a single unit, that gets pretty easy then. But some of these cases can be much more complex. But keep in mind this: patients, my doctor friends, restorative doctors, because you're the last one to touch the patient while putting a crown in. Patients, when they hold the hand mirror up, they're evaluating you, not necessarily the implanting surgeon, if that was a different person. They're evaluating you, what you did for them, by pink and white. So what I mean by that is, not only they're looking at the crowns, but they're looking at the pink. When they think of a natural smile, non-dental IQ patients, if you will, don't separate the gums from the teeth, the pink from the white. It's all part of the smile. That makes the beautiful smile. So it's important that when we're looking at these cases and thinking about our prosthetic options, we need to be thinking a lot about bone. We need to be thinking about what's that bone doing for us, for this patient. And keep in mind that bone is what supports the tissue. So here, if you didn't have any interdental bone, you would not have an interdental papilla. The biological width is dictated a lot based upon proximal contact location and height of the interdental bone. So if you're doing a case in the aesthetic zone, and it's going to be an immediate extraction, immediate placement, atraumatic extractions are really critical. You do not want to lose any of the buccal plate, palatal plate, but people forget about that interdental bone. So that is something that you want to really preserve, because that helps to prevent that black triangle disease. So to help do that, I mentioned already atraumatic extractions. Based on how much bone loss the patient has had, some periodontal disease, they may end up with an FP2 and not be an FP1. Evaluate for correct biological width. Biological width, we'll be talking more about that and giving some pointers on that. But consider, bone grafting, at the time of implant placement, or maybe it might be a scenario where we need to graft and then come back later, and same with soft tissue grafting. So here we go. So biological width is really defined as the maximum height the gingival tissue will maintain itself from the crest of the alveolar bone, which, basically in many cases are individual crowns and maybe just, a couple of 2-3 crowns, is the interdental bone. So the average on healthy natural dentition, the average biological width, or that is about 3.5 millimeters from the interdental bone to the proximal contact, is what they found is kind of be a norm. Now, this can go all over the map. Some of our great colleagues that have taught us so much over the years, Dr. Marie Salama, Dr. Henry Salama, and David Garber. These clinicians have done so much to help all of us to provide better for our patients, but they've done a lot of research. They've got articles on this, but there's a difference what you can expect based on, is it a natural dentition adjacent to a natural dentition we just spoke about, or natural dentition to a pontic, or a pontic adjacent to a pontic. So you had 2 pontics on a bridge, or an implant adjacent to natural dentition, an implant to a pontic, an implant to an implant. So there's information here that you're going to need to, do some more research, folks. Write down biological width. Write down, the Salama brothers, Dr. Garber. Look them up. Look at some studies. Dental XP. They have some great information there. Join that. But you need to understand this, because this is where a lot of people do not meet the patient's expectations. They don't understand how to plan for that and sometimes manage that as well. So let's keep going on about our restorations here. I want to take a moment here, because I'm going to get into some things that, I'm into the age now where I look back to who, some of the people that I owe a lot to. This gentleman, Dr. Charles English, we lost him way too early. I spent 2 days locked up in a hotel with him when I was doing a chapter in the book on biomechanics and prosthetic options. And he was so kind to me. And in 2 days' time, we came up with this list. And, that's pretty extensive, but wait, it keeps on going. It was just amazing. It's a snapshot of what we need to be thinking about. Not everything is going to pertain to your case, but you need to know your little pilot checklist. Your pilot checklist right here. So you need to know, what are some of the limitations and some things you need to consider. We're pre-surgical treatment planning. You haven't placed an implant yet. Really, we're talking about, this is your evaluation to doing this. It's not just a matter of doing an iOS scan, a CT scan, and shoot it off, and there, we're done. It's done that way, and in many cases it works okay, and sometimes it works really fine. But when you get into more complex cases, or you're getting into cases that are reconstruction cases where you have more variables involved and it's not so straightforward, these are the things that you're going to need to know to fall back on to be able to meet those patients' expectations. So there's some, most people are doing screw retain now. It's funny, we started out, everything was screw retain. And then, in the early 90s, everything started going to cement retain. They didn't like big screw access holes, and it was ugly, and aesthetics were an issue. And it went cement retain. Now it's reverted back to screw retained. But there are indications and contraindications for these. And I think that what's important is that we understand some of the limitations to each one of them. And so for a cement retained restoration, that, these require them a little more interarch space, restorative space, than say the screw retained prosthesis. And so one of the things I'm giving you just some guidelines. These are not engraved in stone. It doesn't fit every patient. These are just some good guidelines for you. It's like saying the speed limit's 55. Well, if it's icy out and it's snowing here in Minneapolis and you're coming up onto a curve, the sign says 55. You're going to do 55? No, you're not going to do 55. You're going to use common sense. You're going to slow down, etc. So that's what I'm trying to share with you, are some of these cautions and warning signs to just say, take a moment, pulse check. Where are you at? Are we doing okay? Let's keep going. So The inner arch space for a cement retained, really you're looking at about at least 4 to 5 millimeters, and that's going from the crest of the soft tissue to the occlusal plane of about 4 to 5 millimeters. You get less than that, you're going to have problems with the retention of the crown onto the abutment. And so I'm also just saying here, my little note posted here on the bottom, that that's assuming that people have an average of about 2 millimeters of tissue. So, if you went from the platform of the implant, that's where your abutment can kind of start, maybe a couple millimeters up here. So you get some running room, if I can use that phrase, running room of the abutment above the tissue for the crown to cement onto, or just slightly subgingival, to give that crown more surface area to cement to. The advantages, you don't have to screw access holes. You're following more of a normal post and core kind of crown and bridge procedures. Disadvantage, again, you need more room. Retrievability is not as predictable, and you may have excess cement. Pre-cement these outside of the mouth. Put some cement in there. You should have you can have a dye made, or even a little impression. Squirt some impression in the crown, put a burr in it, and then pull that out. There's a little pre-cementation dye. So you put cement into your crown, put that little impression dye in there, pull it out, wipe off push it in, wipe off the excess cement, and you have just about the right amount of cement for that. That was 20 seconds. That usually takes about a minute and a half to explain. So things to consider, though, to help with cement retained restorations, that evaluate parafunction, night guards, minimize the spans. Multiple pontics can create a little bit more problems. Minimize your cantilevers, or if not eliminate them, at least minimize them. If you're dealing, with crowns, some type of surface roughness inside. This was some numbers that were done here when we were doing a lot of the metal crowns, which are still done. Just roughen the abutment itself, make some mechanical retention on the abutment itself. And, if teeth are mobile, adjacent teeth are mobile, avoid splitting them to implants. Watch for off-axis loading, as that can cause, and you're going to see that when I get into biomechanics coming up here, that can accentuate loads. And then horizontal loads, again, occlusal scheme, functioning lateral excursive movements, clearing in eccentric movements, clearing and no balancing interferences, multiple units, especially cross arch. You're going to go with your group function. So let's take a quick look at some screw retained indications, contraindications. Typically, with your screw retained, the abutment is separate from the crown, but the laboratory would typically do some type of cementation to that. Milling nowadays, we can mill pieces, but you're still going to have the hole through that, where the screw is going to engage the connection of the abutment into the implant. The screw is actually going through the crown, through the abutment, and engaging the internal threads of the implant. And then to the degree you can mask that occlusal access hole for aesthetics, you meet the patient's aesthetic expectations. So indications here, there is a minimum. And really the minimum and I say this, is from the platform of the implant, which is going to be the base of the abutment, to the screw access hole, is really 3.5 millimeters. You've got to have some room for these restorations. So on this I'm showing you now, I took away the tissue, and I'm just saying, from bone level to here, if you're treatment planning this case and you're thinking about what am I going to use, that if you don't have, because sometimes you get super eruption, the opposing dentition, if you don't have room here, you can't do anything about it, So you do need some room, folks. That's the bottom line. Some contraindications with screw retain, where you may have to have some type of a superstructure made is where you have all this divergence, especially if crowns implants are angled out toward the facial. Now you may have screw access holes coming out on the facial. And again, aesthetically, how are you going to manage that? It could be a problem. So just keeping implants, you just it used to be years ago, oh my gosh, we used to hear it all the time. the surgeon would say, the implanting clinician would say, well, I can only put implants where there's bone, and that's why their implants were all divergent, what have you. Well, bone grafting is very predictable. It has been for years and years. So if you don't have the bone there, grow the bone, especially horizontally, it's very predictable to grow bone, and put the implants in more of an ideal position. And advantages, again, it is more predictable for removal. Better retention when you get short clinical crowns, better retention. And abutment to implant interface might be a little bit about bacteria. So here's just some things to think about, splinting versus keeping the crowns independent when you have multiple units. I was asked this, and still are asked this a lot. And so here's just some data that we've known for many years that, it's a higher success rates when you splint two crowns together. I remember reading some of the articles that said when you splint two crowns together, they can withstand twice as much off-axis loads as an individual crown, which can be significant in certain occlusal schemes. Also, which is also great, she talks about, less screw loosening when you're splinting, as well. So that really helps a lot. The key, though, I really do think, is that it's less stress to the entire system. The system being, the componentry, the bone to implant interface, the prosthesis, and then easier to remove. That just means that if you had two crowns, you're trying to get them off, you can put something underneath those and lift up on it with some of those different crown removers that they have. So I just kind of wanted to share that information. So here's some other tips. I'm not going to go through, too much of this. I think the biggest ones is you got to be using the torque drivers. Doctors, if you're getting into implants and you don't have a torque driver, you don't want to spend the $500, or a lot of them are less than that, but get you a good torque driver. Don't be doing implant dentistry because you're not going to get the proper torque. There's ideas when implant manufacturers say they want you torque an abutment to an implant at 30 newtons or 35 newtons or 32 newtons. They've already figured out mechanically, the goal is to find the yield strength to get that clamping force so you don't have screws loosen, minimize off-axis loads, minimize the crown height. We're going to talk about that coming up on crown to implant ratio. And then, of course, minimize cantilevers. If you can, eliminate them, minimize them. And then, night guards are very helpful for these patients for long-term success with their restorations. So continuing on about the screw loosening, again, even using full arch impressions really helps the lab to get the occlusion just right for you. Pontics, watch out for multiple pontics. 2 pontics or more. Again, I found this all in Mish's book. Look at the flexure. This is on metal, of course, noble metal, but look at the flexure rate. We start adding, you get 3 pontics. This is incredible, and that can cause the ceramic material to fracture, etc. So, things to think about when you're designing this. So my technician friends or dentists are counting on you to know this information. So now we're going to get into, I really love biomechanics. I think this is really cool because to me, basic biomechanics, and this is really the basics. This is going to be the things you really need to know, these fundamentals, or you should really know them. Someone on the team needs to know them for the patient's sake, but it does require planning. And then it's really a balance because there's a lot of different philosophies, if you will. They don't contradict each other necessarily, but some might be a little more to the extreme than others, and we can get by with things. And the advancements of some of the materials that we have, the implant manufacturers, surface treatments, etc. So I think this was a statement that I've been saying for probably 20 some years because it hit home with me, is that the treatment planning process, both surgically and restoratively, must focus on the distribution of stress generated during functional loads to the degree, my friends, that you can share or distribute the loads when a patient goes into function in greater area as possible and as quickly as possible. You're going to have that long-term success with these restorations. So we got to understand biomechanics. So here we go. There's really 3 types of forces of occlusion that you'll hear about. Sorry. And so one is compressive forces. Those are forces that tend to push objects together. Then there's tensile forces, which is kind of the opposite of that. It wants to pull objects apart. And then the other one is shearing forces, which wants to disrupt the interface of objects, be it porcelain to the understructure, be it a zirconia core or metal core, even a denture tooth on a denture. But what we do know is that cortical bone is strongest under compressive forces, as 30% weaker under tension, that pulling. But check this out: shearing forces 65% weaker. That's cortical bone weaker on shearing forces, and you're going to see that a lot of shearing forces kind of start to occur when you start when you start having off-axis loads, and they're not splinted in a cross arch stabilization. Okay, so there's a lot here. We're not going to cover all this. I'm going to just hit some high points of this. But so one of the key things, and I'm really surprised and disappointed of how many young clinicians and technicians really aren't aware about the 4 qualities of bone. I'm fortunate I get to lecture quite a bit in person, and I ask people to raise their hand if they understand. And I'm seeing in today's world, in the last probably couple of years, almost 20% of the people don't know. And I'm sorry, but these are dentists that I'm working with that are in the audience, many of them, and they're not aware of this. So let's cover this. So this is extremely important. Bone quality means what to a patient? It really means, when do I get my teeth and how much does it cost? And the reason I say that is, when do I get my teeth? It's about loading protocol. Poor quality bone, you're probably going to have that go a little bit longer than better quality of bone. So time is very important to a patient. Money, if you're doing something in the posterior quadrant of the maxillary, and you're replacing 3 teeth, it may be best to do 3 implants instead of 2 implants and a pontic, because of the poor quality bone. So cost could be an issue. So bone quality has a direct correlation to patients' expectations, which is about time is one of their issues as well as money. All right, so this is again, Dr. Carl Misch coined these phrases. This goes way back, and these are standards we all go by. So type 1 bone, another phrase that used for this is D1. Like you might hear type 1 bone, D1 bone. D, the letter D, represents density. So some people say density 1, density 2. Some will say type 1, type 2. So type 1 bone is frequently, most often, found between the mental frenum and the mental frenum, the anterior, the mandible. And that's also referred to as like oak wood, to kind of give you an idea of the density of it. Type 2 bone is commonly found distal to the mental frenum. The lower mandibular posterior area is commonly type 2 bone, and it's been related to, similar to spruce wood, if you are familiar with the densities of wood. We've done any woodworking, of course. Type 3 is typically found in the premaxilla, and that's referred to as balsa wood. Us older folks, you remember those little planes we used to buy in those dime stores, and you put them together and you throw them, and you look at them and they would break almost. But balsa wood. And you're also noticing that the inside, within the bone itself, it becomes more trabecular, especially when I throw this slide up, this image up for type 4 bone. It's almost referred to as like styrofoam, because look at how the trabecular type 4 bone is compared to type 1 or D1 bone. D4 bone commonly is found posterior maxillary. Now, it's not just a delineation cut off from first bite to canine where the bone changes. I mean, you may find, type 2 bone in the premaxilla. You may find, D1 bone in the posterior here. So it's just, be aware of it. Tactile sense, looking at today's software, also a lot of times it can tell you what the bone densities are. So it's one thing to know about the bone quality. The next thing is to know what is the available bone. Bone's measured 3 ways: height, width, and length. And so that's why your CT scans are so important to have. And I know most of you have these now, but that's going to CT, that cross-sectional image is going to give you your width. So let's talk about the angle of the implant. So this was interesting. Dr. Paul Binen, a wonderful prosthodontist out of and from California, just a wonderful person. He helped also in some of the things I was doing in the book. And I learned this from him, that this article that he did is that, and I found this interesting, for every 15 degrees, the load is off the long axis. About 25% of load is transferred to the abutment to screw connection right here. And what else is happening right there? That's your bone to implant interface. So now if we have magnified forces right there, and if we're worried about, these shearing forces, tensile forces, so off angle on a single unit can be detrimental. Now, we're angling implants all the time when we're doing these full arch cases, the all on X type of cases, but that's different because we're doing cross arch stabilization. We're splinting everything. This is talking about a single unit or maybe just a unilateral bridge. But here, specifically for a single unit, is what this was about. And so it's really important. Yeah, the loads looks like it's going down the long axis of the crown, but it's not going down the long axis of the implant itself. Opposing and adjacent dentition, what to consider from the biomechanics. Obviously, partial is not going to be, is going to give you more forgiveness than an implant supported bridge or crown and bridge on natural dentition or dentures. So these all play a role in it. You want to understand, what's the musculature like? What's the is there a parafunction? What's the bone quality? How long is the implant? How wide is the implant? Is there parafunction? I mean, it's like this little checklist. You just need to pop off when you're evaluating the patient, evaluating the case. Those things, you need to always have those in the back of your mind. So parafunction. So, bruxism, we keep thinking about what bruxism, could be a contraindicator to this, to implant dentistry. In some cases, it should be. You need to evaluate that. But there's another portion to this too. Yeah, we can put them in splints, do patients, night guards, et cetera. Patients need to understand it's in their best interest to do that. But the other thing too, again, from, information from what Mish has shared with us over the years, is that clenching. And this is something that I didn't understand about fractions on crowns. I thought that was abrasive from people brushing too hard. To understand that clenching has an effect on this, and clenching is a type of a parafunction. So things to look for. Look at the other side of the mouth. What's going on in natural dentition here? If they're edentulous here, there's a story to be told on this other side. Okay, so a lot of things to take into consideration here, and then occlusion. This is really basic because occlusion in itself is probably, if not an hour conversation, it's close to that. But keep in mind that we have, because there's a lack of a periodontal ligament, our crowns, it's like you're dealing with an ankylosed tooth in the arch, in the alveolar ridge. So there's a lack of periodontal ligament. And because of that, there's a lack of proprioception for the patient. They can't always tell how hard are they biting. You want to try to have your axial loads, loaded axial loads, the occlusal loads that we just showed. Avoid premature contacts on your implant crowns. The occlusal scheme, on single crowns, you want your crowns protected in excursive movements, in all excursive movements, eccentric movements, that's every movement other than centric. So you want your implant crowns out of that occlusion. Canines, kind of tough to do that, but then you need to look at and evaluate how long was that implant? What's the musculature like? A lot of, those other things. And even the cusp and angle inclination, cusp-foss relationships. You don't want to have them too steep. Maybe you don't do a 33-degree type of anatomy on a tooth. That should be more of a 5-degree or a 20-degree occlusal scheme, just to prevent having any contacts and excursive movements. Told you that was going to be a real brief on occlusion. So then crown to implant ratio. This is something, again, that I see that people will miss, and, pardon me, and they don't, think of crown to root ratio. Well, what's different here, and this is important to note, when we're talking about crown to implant ratio, it's the definition of it is, or it's measured from the occlusal plane to the top of the implant. This is all crown. Even though the clinical crown may stop here at the collar of abutment, it is functioning. Occlusal loads don't notice the difference, okay? It's functioning as the crown. Basically, anything above the platform of the implant is crown ratio. The implant into bone is implant ratio. Now, something to keep in mind though, implant ratio isn't necessarily just to the top of that crown to the apical of the implant being, say that was a 10 millimeter implant, that, and I'll say that's a 15 millimeter implant and 10 millimeter crown, make the math easier on me. You know, it's 1.5 over 1. That could be really good. And most people feel very, very comfortable with that dimension. However, if you had bone loss here to the first thread or second thread, that crown, that implant ratio is no longer, 15 millimeters. It might be, if you're 2 millimeters of bone loss, that 15 millimeter implant is really a 13 millimeter implant, et cetera. So you have to look, so implant ratio is based upon implant to bone, call it integration, because, when we're really loading these cases for the final loads, that's what we want to have. So that's just, the ratio 1-to-1, an equal amount of crown ratio to implant ratio is, people feel pretty comfortable about that. But now think back to your poor quality of bone. Maybe it's a narrower implant. Maybe there's some parafunction. Maybe there's some health concerns. Then look at the ratio, put the ratio in your advantage. Try to go with a longer implant. Minimize that crown height. Okay, these are just real fundamental things to be thinking about. And then here's just a snapshot about it, as I was just kind of alluding to, is that evaluate what was the bone quality like, the diameter of the implant, angles, parafunction, cantilevers, opposing dentition. All that plays a role into selecting the best outcome for your patient. So now we're going to talk about cantilevers, because this is something that I think people don't take enough to heart. Please know this. Cantilevers are really nothing more than a magnifier of force. Those of you that have ever had trying to get a bolt off of something and it's stuck and you got your wrench and you're trying to pull it, you can't get it. What do? You put like maybe an extension, put a piece of pipe over that. Now you get out here and oh boy, it's a magnifier of force. A cantilever is a magnifier of force. So we need to be thinking about that when we have cantilevers on our restorations. So there's do's and don'ts about it. There's more don'ts really with cantilevers. I mean, again, always try to minimize them or eliminate them. If you have to have a cantilever, maybe consider seeing if your implant position, instead of putting a cantilever pontic posteriorly, could you put that pontic, cantilever it anteriorly and put your implant posteriorly, so you're cantilevering to the anterior as opposed to cantilevering to the posterior. Because we know that, the biting forces at the first molar are 4 times greater than the biting forces out here, the incisors. So the closer we get to the hinge axis, the greater the biting forces. So if you're cantilevering and you're going closer to the hinge axis, it's just going to magnify the force even more. So if you're going to cantilever, splint implants whenever possible. Use longer, wider implants. Cantilevers, I just mentioned, toward the anterior. And again, there's my buddy Charlie, Dr. English, showing up on articles that he did. This is information we've known for a long time, folks. The body hasn't changed. We still make people pretty much the same way we did back when we started working with dental implants. So a lot of these considerations are still important to take into consideration and to respect. The don'ts: don't cantilever with parafunction. Single implant, don't cantilever off a single implant. Short implants, oh boy, watch out for that. Poor bone density, poor bone qualities, interchangeable phrases there. So in summary, with cantilevers, again, avoid if possible. Contraindicate with your bruxism, and we just kind of covered that a little bit. Minimize the length, use additional implants would be better. just evaluate all these things when you're even thinking about doing that. Now, coming to the AP spread, anterior posterior spread. And once again, thanks to Dr. Charles English, I believe this was 1986 or it was 1988. I forget which year it was. It's called the critical dimension of anterior posterior spread. And so this is how it's defined. So anterior posterior spread, AP spread, really important when we're talking about doing our fixed full arch. And yes, it does go into your FP3s or your all-on-X cases, but it also can be for your overdentures, which we're going to cover that in section part 2 of Implants 101. We're going to focus a lot on the whole overdentures things. So what you do is that you draw a line through the center of the 2 most posterior implants, and then draw a line to the center of the 2 most anterior implants, and you measure that distance. That's your anterior posterior spread. This particular scenario, we're calling it 8 millimeters. Well, what I always say is that Dr. English came up with, I call this the magic number. It's 1.5. So you take the AP spread, that number, and you multiply it by 1.5, and then that gives you the maximum that you should cantilever posteriorly. So in other words, for this patient, the maximum cantilever according to AP spread would to go 12 millimeters. Now, that's not to the crown. If this was an overdenture, like a bar overdenture or something, that's to the extension of the prosthesis itself. If the patient bites down on a bolus of food, I like to use the analogy of the raw carrot. They bite on the raw carrot and it hits past that first molar or second molar on your prosthesis, and it catches a bit of the extension of the prosthesis. That is, I mean, that's part of that cantilever as well. So you don't just automatically go 12 millimeters because the math says that. It's back to that sign on the road saying 55 miles an hour, but it's on a curve, or it's icy, it's snowing. You have to look at what's the opposing dentition. Oh, it's a full implant supported bridge. They've got some indications of parafunction, poor bone quality, etc. These are things that all need to all play together. So you can't just get until you get that talk track in your head and looking at all the different things, the length of the implant, how wide the implant is. But this is what AP spread's about. Now, what some people don't realize is AP spread can be affected, improved, or more challenged based on arch form. So let me show you that. So with a tapered arch, you'll see that here you probably can get a little bit, you're probably more able to get a greater AP spread. If you ever do have that 5th implant, which I think is a great thing to do, by the way. I mean, they say all on 4, none on 3. If you're placing 4 implants and you don't get enough, if you're doing the immediate load cases, that 5th implant can be a game changer. But don't worry about trying to draw. That's just a bonus. Don't try to draw a line through it and measure. That's just a bonus implant. So here we have, an AP spread of 15 millimeters. Just don't, evaluate everything before you go much further. Here's more of an ovoid arch. Maybe here it's a little harder to get, an AP spread. But what happens when you get a square arch and you're keeping the implants between the mental foramen and they're all in a line? Well, quite frankly, here it's contraindicated to even cantilever a tooth off of that, or cantilever if you're doing a hater bar or some type of a fixed prosthesis to come off of any extension posteriorly of that. If it's not contraindicated, you really need to look at all the things we keep saying: musculature, parafunction, opposing dentition, etc. I know I'm a broken record, but if you do that yourself, it'll keep you out of trouble. So, when you're looking at implant position and placement, and we're going to really get into this much more in depth in part 2, in Implants 101, part 2 on December 7th, because I really want to really dive into this more when it gets into our overdenture and full arch cases. So splitting the natural teeth, we're going to wrap it up here on the biomechanics with this. And really, teeth don't support implants. Implants support teeth, meaning that if you do splint, and I'm going to show this coming up on another slide, so I'll just save it for that. But splinting the natural teeth, you really want to be thinking about why are you doing it. If you're doing it for cost reasons, then you really need to make sure you're going to listen to the next part of this next slide coming up, because they're different animals, if you will, a natural tooth with periodontal ligament versus an implant integrated into bone. And based on where they are in the arch, they function differently. So implants support teeth, teeth don't support implants. So let's take a look at this scenario. Here we've got, and boy, I can tell you, I did a lot of these cases back in the late 80s. Mainly in the early to mid 90s, we used to do a lot of these. We would do a telescopic crown on here, sometimes put a stress breaker in here. I probably did more stress breakers than doing telescopic crowns. But the thing is, what you have here is this is a cantilever all the way coming from here, because if there is a stress breaker in here and you put an occlusal load, that cantilever, what's going to happen is when that load comes down here, this portion, you're going to watch if you get a case, if you inherit a case like this. So some younger clinicians, a lot of cases were done like this over the years. So if you inherit this in the practice that you joined or you recently took over, take and evaluate, look for saucerization or bone loss here on the mesial, and you're going to see it probably on the mesial and maybe also on the distal, but on the mesial, because what happens is, and on the distal, especially the distal, I apologize. Because when the load comes down here and it gets a little teetering like that, the bone right here, the bone implant, this bone is under more of a compression force. And because this is wanting to lift on this side, because the bridge is wanting to go like that, that is under tension. And we just looked at tensile forces are 35%, are 35% more stress than something that is more than compression strength when it comes to forces of occlusion. So, minimize putting in kind of a cantilever here. If you splint to a natural tooth, think about why are you doing it? Are you doing it to save that tooth? And how long, and at what risk are you putting that implant doing that? What's our best solution here, really, if we're thinking about this for long-term? Patients want this to last a lifetime in 2 days. Yep. Really the best thing to do here, yes, it's going to be additional cost, but they're going to forget that you saved them money when 10 years, 12 years later, the things are failing. They have limited retention of all this technical stuff that we're throwing at them. So really the best scenario here, if you're going to splint to the natural teeth, is you have these two implant restorations splinted, and now you're doing something to save that tooth by doing that. So take it for what it's worth. So the last thing, and we'll be wrapping up and start taking questions here, is the team concept. And really, this is, hopefully, we haven't lost this, because communication seems like it's just changing these years. And we can't lose the communication when we're doing these cases. The more complex the cases, the more I really believe to get the success that everyone on this call, what you're looking for, what your patients are expecting from you, which all of your members of your team are expecting, is long-term results, and not have to remake things. You do a remake, it takes 5 times in a laboratory. A remake, a no-charge remake, takes 5 new ones to make up for that one. It's a no-win situation. It's same with your clinicians. So communication is extremely important. So share the patient's expectations with your laboratory. That means you may think about, well, they're not going to see the patient anyways. But let me tell you, it's trained technicians that work with implants. They know, based on if you tell them what a patient's looking for, that will help them in how they design restorations, how many implants they may plan for the case, whether it's going to be tissue supported, bar supported. So there's a lot that a trained technician can really help support you with. Let them know what you're thinking about. What's the patient thinking about? Again, what are all the complete expectations of the patient? And please, implant dentistry, full arch impressions, or full arch models. Quadrant, I mentioned this earlier on, the bigger the case, just do full arch, especially your scanning. Now you can say patients are gaggers, they don't like it. Well, you always gonna have the patients that are gonna be a gagger, but don't throw the baby out with the wash water and do everything shortcut, because some patients may gag, or it might cost you $2 more impression material doing a full arch, what have you. Study models also are very helpful patient's existing dentition. It helps the technician to see the occlusal scheme, help them to see where the neutral zone was, where things were, what they had. Because again, a trained technician could do so much to help enhance the outcome of this case.